that helped define who he is today in healthcare. And one of the first really successful stories that he had from a payer's perspective, from an insurer's perspective, is when he was called in to work with the Walmart Corporation, another Arkansas company, of course, who happens to be the largest employer in the world. And Nick was instrumental in revamping their self-funded health care program. And as a result of some of the recommendations and the protocols that Nick put in place to their health program, Walmart credited Nick with having saved their system about $138 million within the next 12 months of operation. So that's a huge feather in his cap. The only reason I make mention of that is for something we'll discuss a little bit later, is why Nick is somewhat uniquely qualified to be doing what he is currently doing, is really tied into the fact that he had extensive experience on the payer side of the table, and he totally understands what it is that insurers are looking for from physicians to unlock value in the going forward economy, where we're always looking at value-based contracting. And so continuing in Nick's timeline of history, after he left the payer side, he decided he wanted to be he was a forward thinker, and he wanted to do what he considered to be a better primary care model, or proactive primary care. So from about 2007 through 2011, Mr. Smith started up from the ground floor, built 28 primary care clinics that he owned and operated with a couple of partners. And within their 28 clinics, obviously they employed hundreds of medical professionals. I think at his peak, he had 42 primary care physicians on his payroll, and all the hundreds of supporting staff. But it was a great laboratory, to use that phrase, for Nick to experiment with his idea on what better primary care could look like from a business model. He's not a physician. He's an entrepreneur, and he was really trying to define what he thought would bring to the insurers, to the payer side, a better model that they could get behind. And so for about 5 years, as I said, from 2007 to 2011, Nick had the opportunity to own and manage these 28 primary care clinics. Things were going extremely well with it, but as happens from time to time in partnerships, there were some differences of opinions. Nick had an opportunity to expand his business model into several hundred locations, and his partners were somewhat reluctant to do that. This was because at that point in time, to date stamp it, around 2011, of course, is when Obamacare, the ACA, was really starting to look like it was a real thing. It's going to be the law of the land, and there was a little nervousness among his partners. So Nick actually sold out of his primary care business at that point in time. This was synonymous with the time when accountable care organizations were starting to prop up. And so Nick actually stood up the first one. In fact, I think he stood up the first and second accountable care organizations, served as their CEO. This is for the state of Arkansas, by the way. And over a period of probably a little bit less than a year's time, Nick had been contacted by a new business division of CMS. CMS had started what they call their Innovation Center. The Innovation Center had a mandate to identify different new and emerging leaders in healthcare, and also to experiment with innovative methods for delivering healthcare services to Medicare recipients at a better valued rate as far as Medicare was concerned. So around 2011, 2012, in conjunction with what he was doing with his accountable care organization experience, Nick was encouraged to apply for Innovation Center funding by CMS. Among the 1,100 some odd applicants, Nick was awarded this Innovation Center funding, and it was a significant grant. To be just very candid, there were millions of dollars of revenue, excuse me, millions of dollars in the grant that were given to Nick, with the stipulation that he would try to be a pioneer in developing what would be considered improved primary care services, particularly those that were proactive in nature or preventive in their nature. And so with the assistance of working with taxpayer money, your money, my money, et cetera, Nick had the luxury of doing a lot of things that ultimately led to the current business model that we'll be discussing here. So I just think it's important from a historical perspective, you to understand that what we're going to be talking about, the methodologies that we will discuss, are really not things that were just developed in a vacuum or in theory, but they're actually developed from the experience and the exposure that Mr. Smith had actually owning and operating clinics, being on the payer side of the equation, and fully understanding what it is that CMS is interested in incentivizing as the major payer in the healthcare industry. So that's kind of my 5-minute background information on why we do what we do today. In 2014, Nick basically had aggregated enough of the information. He had proven enough of the processes worked well. So he launched the company that we currently have, the Practice Improvements Corporation. It was launched around 2014 with a small handful of clinics that Nick had agreed to give a try, that they'd agreed to work with Nick as participating practices. And from that initial 20 clinics in 2014, we started 2018 with just shy of 200 clinics that are partnering with us. Sitting here today, the first day of September, between our clinics that are up and running, those that are currently in the implementation phase, and those that have signed contracts, we're pretty close to 300 clinics. So this 2018 has been a year of significant growth for us. Let me move on down through a slide deck now. So our healthcare industry, I think it's no secret, it's got a problem. The problem is it has not been sustainable. It's been on an unsustainable spending curve. When the ACA became the law of the land, there were roughly 9 million newly insured patients that got on the rolls of some insurance company somewhere. At the rate, I'm a baby boomer, at the rate that baby boomers are coming into the Medicare rolls, at about 10,000 newly enrolled patients every single day. That is not expected to change for the next 20-something years. Obviously, there's more and more demand for healthcare services in our nation. That's creating really soaring healthcare expenses. 2017, Medicare spent just a little over $10,000 per registered Medicare beneficiary. That in itself is a staggering number, but the more staggering number is the spending trend. It's expected that that $10,000 per patient per year is going to increase to over $15,000 per patient per year by the year 2025. So we've got this exponential growth taking place on spend, spurred in large part because we have lots of new people on the insurance rolls, more and more baby boomers, and we're costing more. The services are costing more on an annual basis. The net result of some of the legislation that's taken place, whether we were talking about the ACA or if we were talking about MACRA, is that a lot of physicians have decided they're leaving the industry. We are expected to have perhaps as much as 100,000 physician shortage here in the near term. And oddly enough, as much as America spends, we by far spend more than any other nation, and perhaps we spend more than most other nations combined do on healthcare. In the modern quote unquote high income nations, Our healthcare is not ranked anywhere near the top. In fact, most of the reports would say of the modern healthcare nations, America actually ranks near the bottom. I've seen it rank 11th. I've seen it rank 13th, depending on which report we actually look like. So I'm just had a request pop up here about screen share. Is the screen not sharing?
We're not seeing your screen. We're not seeing the presentation.
Well, it says it's sharing. So what is going on here? Let's try it again here.
Ron, I'm not seeing it, but I know when you're speaking, I know which slides to pull up. So I've been handing him the slides that should be
there. We see it now.
Okay. Yep, it was probably stuck in a queue on an older slide deck. So the industry solution, you guys, thank you for bringing that to my attention. The problem has been the unsustainable spending curve. The industry solution, and by industry, we really mean the federal government. They are the primary payer of healthcare services in our nation. In 2012, the Affordable Care Act came out, promoting the triple aim of better quality of care, better patient outcomes at a lower cost. The Affordable Care Act created a few incentives with very little downside to physicians. However, in 2017, with the approval of MACRA legislation, there actually became downside risk associated with physicians who were underperforming. And for the first time in our existence as in healthcare industry, physicians were going to become graded against each other, and how they performed relative to peers was going to actually have an impact either positively or negatively upon their income. So 2017 was the base year where metrics were obtained by CMS and on all physicians. 2019, next year, we'll actually see the first of the penalties being applied. The legend holds true, and they don't defer to delay it. So the industry or the government solution to the unsustainable spending curve was to enact additional legislations, as we've described, and they were basically saying, hey, we're going to no longer just pay someone for performing a specific service. Those fee-for-service days are over. We're going to gradually wean you off of that, Mr. Physician, and we're going to push you towards value-based contracting or value-based healthcare services. And we're going to start off by putting a carrot in front of you, which is the upside that's currently there and exists. But as we continue further down the timeline of MACRA imposed legislation, we find that the carrot, although it's initially just a carrot being held in front with this nice long stick, in time, that stick that was holding the carrot actually becomes the stick that whips the horse, saying, hey, we need a little bit better performance out of your horse. So there is some real downside risk. And I think the first wave of pain relative to that downside is what will begin experienced by many physicians in 2019. It's too late to change what their reimbursement factor will be up or down for 2019. That was determined already, but it's not too late to change the ones moving forward. And moving forward, 2020, 2021, et cetera, the penalties are actually doubling and they'll be much more severe than they were in 2019. So the net result is there is some downside risk to all physicians currently under the terms of MACRA, whether they're on the MIPS track, which is about 90-something% of the physicians, or those that are in the alternative payment models. There is truly downside. But the nice thing is there's also some upside. We'll talk a little bit about it. The practices who can strategically embrace the direction the payers are pushing physicians towards proactive medicine rather than reactive medicine, there is some significant upside on that. So let's go to another slide here. So how do we fit into this equation? Well, drawing on the expertise and the experience that Nick had both on the payer side of the table and also while he was a primary care provider, he's put together a really comprehensive process that's based on gaining population health information and proactively reaching out with very comprehensive patient engagement strategies to bring patients in for high value services. And by definition, when we say high value services, we define that as being the types of healthcare services that the payers have said, we want these services performed. How do we know they want those services performed? The simple answer is anything that they are paying money for it at a premium rate would be defined as being a high value service. It's something that the payer says we want to incentivize physicians. The way we can do that is throw money at it. So what we have been able to do is identify on a payer by payer basis what those incentivized services are, and we help physicians recognize those and capitalize on that. Our proprietary process that we utilize, and the title of my presentation is really Gap in Care Analysis, a key to unlocking value. What is a gap in care analysis? Well, we come into a practice. We know that all practices have patients who have gaps in their care. The payers also understand that. The payers believe wholeheartedly that if those gaps in care can be identified early enough in the life cycle of a patient's disease progression, if we can figure out what those gaps in that patient's care cycle are, and then we can close those gaps in care, we might be able to avert catastrophic care issues later in the life of the patient. And let me just focus in on diabetics for a prime example. Patients, when they first start off with diabetes, it's an inconvenience. It is certainly not limb threatening from day one. But let's talk about a diabetic patient, for example, who has no care or just refuses to have care, doesn't have access to care. As they progress, as their disease state progresses, obviously, many years later in their life, towards the latter stages of a fully involved diabetic patient, we start seeing such things as diabetic retinopathy. We see lower extremity wounds that have difficulty healing. I personally am aware of patients who had wounds that were treated unsuccessfully with normal wound debridement and just normal conservative wound therapy, move on to hyperbaric therapy chamber or to hyperbaric chamber therapy. I personally know of a patient that had over $250,000 worth of hyperbaric chamber wound management, only to still have the end result of when that particular therapy failed. They did the first of several below the knee amputations, trying to stem the problem associated with an infected wound that would not heal. Ultimately, they ended up having to go above the knee into healthy tissue to basically save the patient's life. So it's that type of catastrophic expenditure that's exceptionally expensive. The patients who have multiple chronic conditions that have not been managed appropriately early on are where the huge percentage and the bulk of the spend is occurring in our healthcare economy. And so Medicare and all other payers have said, we believe that it is money well spent on our part to incentivize physicians to proactively start caring for their patients so that we can avert having these major catastrophic spends further down the life cycle and downstream in that patient's care. So what we do, what Practice Improvement does better than any organization I'm aware of, is we deploy our proprietary software that we have written and maintain internally through our IT department. and we do a deep dive into our clients' payer information and also into their EHR system. And the algorithms that we have written help us to identify on a patient by patient level gaps in care that exist. And by definition, a gap in care is really the difference in the care that the patient is receiving as compared to what the best practice guidelines and evidence medicines says should exist for that patient. For example, a diabetic patient with a 1AC level approaching double digits that has not seen a physician in a year's time and has had no med reconciliation. Everybody knows, it's no secret, that patient needs to be brought in, that patient needs to be managed and looked at. And so we go out with our software, we dig into your data, we identify and we start stratifying patients based upon the types of care gaps that exist. We also stratify them, put them in buckets based upon who's paying for it, what insurance card they carry. It is truly a payer agnostic program, but we still need to know who is paying the bills so we can identify what programs are being incentivized by those particular payers. And then once we have performed this gap in care analysis, identifying these patients, we have previously worked through, for example, Dr. Wagner, with you, we would have identified, you would have told us, these are the patients that I think are the highest priority. These are the types of patients that I want to spend my time seeing and caring for on a routine basis. Please help fill my schedule with these particular gap closures as a priority. We actively reach out through our care team coordinator department. Our care team coordinators, some of those are within our corporate offices in Fort Smith, Arkansas, that will reach out and act as an extension of your scheduling department to proactively engage those patients and communicate with them why they're being asked to come in for a specific appointment with you or with your team. We will bring those patients in for visits, appointments that are designed to be gap closure mechanisms. Some of the gap closure mechanisms are what I'm showing you right there, the slide that Trey has in front of you. In the number 2 that's shown there is the wellness visits. One of the beautiful things about the ACA is it required all payers, commercial, federal, state as well, to offer certain preventive services would be made available to all beneficiaries of an insurance policy, and that they would be made available at no cost to the patient. So a high percentage of the gap closure appointments are actually free appointments from the patient standpoint. They have no copay, they have no patient responsibility associated with it. And so as we're going through identifying these patients and then we're proactively reaching out to them on your behalf, we're explaining to them that there's no cost for them to come in for this appointment. The appointment is designed to help you as a physician take better care of them, et cetera, et cetera. And we schedule these patients in and put them on your schedule. One of the other, for example, a wellness visit, Medicare, that particular appointment will bring in approximately, let's say, top line revenue, $150 to $160 for the primary visit. The secondary visits may be $120, the subsequent visits, which is typically a higher reimbursement than what the normal office visit would be. That's Medicare's way of saying we want these performed. They further indicate they want it performed by saying to the physician, Mr. and Miss Physician, not only are we paying you more for fulfilling this health risk assessment and annual wellness visit, but we're not even going to require it to be done by you personally. This can be done under your direct supervision. And so part of the process that we've been very successful with is not only do we line the patients up and bring them in, but we also, if needed, can hire and embed care team coordinators within our clients' practices, or we can simply, if they have excess staff or staff that they believe are being underutilized, we can train their staff just like we would our own care team coordinators to fulfill the mandatory components on a payer-by-payer basis to enable the service to be compliantly billed. So points 3, points 4, points 5, these are just samples of some of the programs that are available that are considered proactive in nature or preventive in nature, that are being reimbursed at some of them very significant levels to the payers. Our process, what we do really well is implement and help practices implement these proactive care management solutions, and we do so on a payer agnostic basis. The most important thing I'll say is we do it in a non-disruptive manner. Most of our clients have the thing that we're really proud of is that they tell us they thought it was going to be somewhat of a painful process, but actually we actually in some of our larger clinics are have been embedded with our own personnel, and some of the physicians don't even realize that we as a company exist. The patients don't know we exist because we're simply an extension of the practice. But we take a lot of pride in saying we do this in as non-disruptive manner as possible. And that came about as a direct result of Nick, when he owned and operated his 28 PCP clinics, he realized there were a lot of things he wanted to get done that he simply couldn't do because it was making significant change forced upon physicians. And the thing that we are adamant about is we recognize that change is not a thing that is easily embraced, particularly in today's society. So the only way that we can really be successful with our process is if we mold our process around the established workflow that already exists within a clinic, rather than trying to make a clinic adapt to our process. We adapt to the clinic's process in a seamless manner so that it is non-disruptive. So, as I indicated, we have our own software. It's been written by our own IT department and maintained. We have the ability, the flexibility to customize this as needed on a account by account basis. We don't have to make a lot of adjustments. Typically, the physician clients never even really see the software. They may see the reports generated through our process. But this is not a software component that you as a physician need to worry about or even know how to operate it unless you just want to. It is typically utilized by our care team coordinators for doing the scheduling, doing the gap in care analysis. If your staff is interested in utilizing it, and we utilize your staff for fulfillment of, let's say, wellness visits, chronic care management, et cetera, most of the time it takes less than 2 hours total training for the staff to be very fluid. The software is really intuitive. It's not the slickest looking stuff. I've seen a lot prettier software, but this is designed to be a workhorse, not really a racehorse. It's designed to get in, get the job done with as little fuss as possible. And so the beautiful thing about the software, though, is that we do actually, we're able to aggregate true population health statistical information. We're able to automatically generate and identify quality metrics and things that you will be required to report on with your MIPS track. And we can very quickly identify those areas where your quality exceeds the benchmarks that will be posted by your peers. And in today's reporting world, the goal is no longer to hit a specific benchmark, but it's simply to outperform your peers. And what we're able to do through our quality reporting module on our software is we're able to identify those specific variables of quality that you should be reporting, because you will be off the chart compared to everyone else in those particular metrics. So in other words, the very process that we take you through to close the gaps in care that the patients have also automatically improves your MIPS scores compared to your peers who are not doing the gap closure methodologies and methods that we recommend. Summing it all up, our value proposition is pretty simple. We typically and historically have been able to take our primary care clinics partners up to twice the top line billing revenue as compared to what they were before we implemented. In a privately owned practice, if we can double top line, it typically more than doubles the bottom line that we see, or that is the net to the physician. Second thing we're doing is we're also having an immediate increase in how the payers define quality of care. And I got to be careful in how I say this, but you know, we're not medical people. We don't know really what constitutes. I can't say this is good quality care, that's bad quality care. A physician is the only one really qualified to do that. However, the people who pay the physicians, the payers, they have their own definition of quality care. And so the things that we do, the services we help fulfill, are producing what the payers call quality of care. And so that's what this is all about. We're providing the payers with assurance that the patients who they are providing benefits to are getting quality care as it's defined by the payer. In essence, what we're doing is we're helping our primary care clinics to transition away from the fee-for-service model, where they were basically paid for reactively taking care of patients that presented as sick patients to the clinic. And now we're easing that transition into proactively managing patients' care, which is in line with what all payers are currently doing. The additional indirect benefits associated with doing our GEICA analysis and gap closures is that we typically see that we lower the avoidable hospital admissions, the frequent flyers to the emergency rooms, the overall health spend on patients is dramatically impacted in a downward nature when care coordination is offered early enough. And so what we find is we've actually gone a long ways towards accomplishing that triple goal, or the triple aim that we mentioned earlier, of better health care that costs payers less but pay physicians more. Well, obviously we know that there's no free money out there. How can you make more money taking better care of the patients and yet us still claim it systemically reduces healthcare costs? It is basically we're taking away future dollar spends from the specialists and the ERs and places of that nature. That's where the additional revenue comes to your side of the equation. I'm going to shift down to just an actual case study, and this is actual data where we were monitoring, excuse me, we'll go back up. We had a owner-operator about 3 years ago at this point in time. They were two physician partners. They had grossed just shy of $1 million in top-line billing in 2015. After they'd paid their staff, paid everything else, et cetera, it was just basically about $180,000 left for each of the physicians to take as their take out of their practice. In 2016, they asked us to come in, do our complimentary gap in care analysis. We identified the gaps in care as we just got through discussing them, and started implementing as a first line strategy, Medicare annual wellness visit. It was a fairly heavy Medicare population in that clinic. That created some significant additional revenue that previously had not been captured by the clinic. 3-4 months later, we added in advanced care plans and chronic care management services to the qualifying patients. Again, there was an uptick in the income to the clinics. Kind of fast forward in 2017, we shifted that particular client off of just Medicare, and we started going out and proactively engaging the non-Medicare patients, predominantly the Medicaid and the other commercial payers that they had there. The long and the short of it is earlier this year, as we were reviewing the data from that particular clinic, it appears that we have more than doubled the top line billing for that particular clinic. And we have added approximately $80,000 a month in recurring revenue to that physician clinic, with a high percentage of that additional revenue, the top line revenue, actually translating straight to the bottom line for our partners. So what I'm comfortable saying to you, Dr. Wagner, and I say it to most primary care physicians, is we generally are able to see a significant increase in our primary care physician partners' income as a result of capitalizing on the gap closure appointments that all payers are currently incentivizing. The end result is you make better money, your patients end up having better care as defined by the insurance companies, and your quality metrics also go up so that you will actually be getting bonus money rather than penalty phase money. A couple of testimonials there, Trey, if you're showing that slide. The very first one there, if you read through it, Dr. Wagner, this is a personal friend of mine, Dr. Randy Tobler. He's actually a gynecologist. He still practices medicine, but he happens to be the CEO of the rural hospital there in Memphis, Missouri. It's called Scotland County Hospital. Randy had tried, he'd had his physicians, they were trying to do their own chronic care management, care coordination. They were doing annual wellness visits at about the national rate, which is 1 in 5 patients that were eligible were getting it in his through his physicians. And he just was not satisfied with the efficiency and the disruptive nature that it was having on their own clinic when they were trying to do it themselves. So they contracted with us to come in. After we had a few little hiccups, Randy was able to make some internal changes within how he wanted the process to roll out. We revamped our programs specific to what his needs were. And you can see that the testimony that he's giving there pretty well speaks for itself, is that lots and lots of satisfaction at the CEO of the hospital level and also at the level of a physician. The other two testimonies that we have there are just random samples. The biggest thing that I can say about our customer satisfaction is this one statement. As of today, still knock on wood, every client that has ever engaged us since we started this company in 2014 is still one of our clients and still utilizing us to help them in many different capacities. We have had a lot of contracts that have come up for renewal. 100% of the clients whose contracts were fulfilled and were at a renewal stage have chosen to renew their contract with us. So when I can sit here and tell you that in the 3.5 years that we've been doing this, we have not lost a client. We still have every client we've started out working with. To me, that's the biggest testimonial that I can throw in your lap. So I'll kind of just back off at the moment and open it up for any questions. Specific, we can talk about any of the concerns or fill in the gap if you'd like at this point, Dr. Wagner.
If you have any questions, go ahead, just speak right there.
I can't think of specific questions right now, but overall, it seems like you have a lot to offer. I mean, it seems to hit a real weakness in our practice.
And you know, Dr. Wagner, what we believe passionately is that most physicians, in fact, almost every physician I personally know, believes in the value of these services that we're talking about. They know it's things that probably need to be done, but they just really haven't figured out how to do these things in a non-disruptive nature. And previously, you know, up until the last few years, you really couldn't do some of these things because they weren't being incentivized appropriately. Today, they are being incentivized appropriately. And the fact that we're able to customize our solution to enable you to continue doing and filling your day with the things that you want to have your day filled with, you get to see the patients that you truly believe need your touch. Where we benefit practices is that all of these other areas that are potentially non-urgent, but they are very, very important because they're valuable healthcare services in the payer's mind. We're able to go out and engage those patients, bring them in, have your physician extenders, whether it would be your own nurses or your PAs, MAs, whatever it is you'd have, or if it's our care team coordinators, we're able to extend services to those patients that aren't truly sick at this point, but we're doing this proactive medicine on your behalf and enabling you to have those revenue-driven components benefit your practice while simultaneously improving the quality of care of those patients. So that's really the number one reason we've been growing so quickly, really without the help of a lot of salespeople. It's just been within about the last 60 to 90 days that we've had people like Trey out in the field talking about what we do. Our growth from 2014 of 20 clinics to this year being, as said, roughly 300 clinics has really come about because of clinicians talking to clinicians. It has not come about as a result of quote unquote smooth talking salespeople. And we're proud of that fact. That you know, we're workhorses. We want to get in there and work for your behalf. What?
Interesting.
Yep.
It
Trey,
sounds really interesting to me.
One other thing too, Ron, I'll mention is both his children are physicians. One is a ER physician in Memphis, close to you guys, and the other one is with Geisinger in what's called Danville, Pennsylvania, which is north of Harrisburg and close to State College.
Oh, excellent. You got a generation going on there. Nice heritage.
Thank you.
You bet. Trey will be, Trey certainly competent to answer other questions you might have. I'm certainly available at any point in time you need, Trey, for, you know, if there's a quick question that comes up, you fire an email out to,
I think probably this step is probably just like with Dr. Holly, send out a sample contract, and so that they can kind of see kind of how it works and get more in the details of how, because I see this as a plug and play for both individuals. And I mean, my experience, I've been in these offices for over 20 years, and actually, odd enough, I met him. I was with Sharing Diabetes, selling diabetes products, and I understand the frustration of what these guys go through every day. And this is, to me, is a great product, and also think it's going to be the standard in the industry. And if you're not on board now, you're going to end up paying for it later through the loss of revenues. And I like to see these guys work very hard for what they do and have a great respect and appreciation. And this is what I love about what Mr. Smith has created is it is a supplement and an aid and a business tool to help these guys survive. And I care about these guys surviving. So.
Yeah, absolutely. And that's truly our commitment. And internally, Dr. Wagner, Nick and I, Mr. Smith, CEO, we always make reference to the fact that we are fixing healthcare one practice at a time. Every time we do a new implementation and we bring on a new client and we start offering or helping them to offer their patients better care, we passionately believe that what we're doing is important. And we do believe that it's a major contributor to fixing healthcare when we're able to transfer appropriate value back to primary care physicians who for my entire life, I'm 60 years old, my entire life, primary care physicians have been underpaid. I won't get into who's been overpaid. That's a whole different discussion, but we are thrilled to know that we, in a small part, contribute to a more appropriate reimbursement model for primary care. I didn't talk, Trey, but I'll just take a couple minutes and won't go too long on it. So how do we get paid in this issue? How does Practice Improvements make any money? What do our fee structures look like? The good news on that is it's pretty simple. We're required to charge a fair market value for anything we do. And so that's what we do. We will sit down when it comes time to contract with us for X service. Our philosophy is let's identify, first and foremost, let's identify how much work is associated with what service we're talking about. Let's look at how much revenue is associated with that particular one. An easy one for me to utilize, again, is Medicare, their published rates, the annual wellness visit. I'll just say the annual wellness visit reimburses, let's say $150. If they're doing a advanced care plan simultaneous with the wellness visit, and that is Medicare's preference, is that both of those services are offered in the same visit, it will routinely reimburse roughly $200. So let's assume that we're brought in to fulfill the annual wellness visits and the advanced care plannings on the Medicare patient population. And let's assume that it's reimbursing at $210 just to make my math easy. If our staff is doing an end-to-end service fulfillment, where the only thing that Dr. Wagner, your team is having to do is actually bill for the service and collect the revenue. If we did everything, scheduled them, we had an embedded employee in your clinic that was fulfilling the FaceTime with the patient for the visit, et cetera, of that $210, when we're doing virtually all of the work with the exception of the billing, we would probably say, let's negotiate a fair market value on that would be about we'll split the pie 3 ways. 1/3 would go to you as pure profit. 2/3 we would take for having done all of the work. Let's flip the equation real quickly. Let's assume that you say, well, hey, time out. I've got Nurse Sally and she's underutilized, or I've got a medical assistant that we brought on. We're considering letting this employee go because we can't keep them busy. Why don't we let my staff do that? I still want to utilize your software, still train them. I still want your care team coordinators and your scheduling department to proactively reach out and bring all the patients in. But let's split the pie a little differently, because we as a practice want to do more of the work. In many of our practices, the amount of work level that they do is such that this pie is split up where we take 25% or 1/3, depending on what kind of work level we're doing, and the practice would keep 75% or 2/3. What I want you to hear me say is that we don't have a fixed determination on this is exactly what we're going to charge you for any given thing, because we really haven't taken time yet to identify what are the components you want to maintain doing yourself or having your staff do versus what do you want us to do. Once again, every one of our programs is a customized solution for what that individual practice needs. But the thing that is in common is that we are only being paid out of new revenue that we bring to your practice. So there's really not cost associated with what we do, because we are proactively, we are actually making the money up front for you. That is new revenue, out of which we will take what we agree is a fair market value portion of that. Your invoices that you'll ultimately pay to us become payable only after you've received the revenue associated with the services that we help fulfill. So there is no, there's no negative or no red ink associated with our process. We have no implementation fees. If we have to write a API to allow our software to better play with your internal EHR and your billing process. We do not charge you any upfront implementation fees or anything for customizing the software. That's just all part of the process we bring to the table. The other thing that I didn't mention, Trey, and you can talk to him a little bit about it, but ultimately through the aggregation of the payer data, that's very important, the population health information, is we know what payers look for to provide more value-packed contracts to the physicians. Again, Nick was the payer for the first part of his career. And part of the value we like to bring to the table is once we have been working with clients for a year and a half, 2 years, and we've aggregated a lot of important health statistical information, we are sitting in a really nice position to help you negotiate better contracts with your commercial insurers if that becomes important to you. And there's no charge for that service. That's just part of what we do as a value enhancement. So that in a nutshell is everything I wanted to say. Trey, thank you.
Oh, I'll let him speak, but it wasn't on speaking.
Yeah, thank you for that. And the explanation was good.
Thank you. We'll just look forward to any follow-up that's needed and just continue coordinating things through Trey. Trey, if I can be of any service to you or Richard or anyone else on the team, certainly reach out. You know I'm available.
Yeah, Ron, I think it was a great presentation. I think you did a great job last night under the circumstances. With all the, the restaurant was a little bit loud there, but I think this is a great situation for both parties, and I think you did a wonderful job at explaining things in detail, and then things ran much smoother tonight this morning than it did last night. So.
Yeah, no problem. We just take it as it comes, and we realize that you can't always have the audience. The background's not always under your control.
Well, one thing I did want to mention, he also is on paper files. So I just want to let you know that, keep that in mind. So. Yeah,
and as I said last night, Trey, that the only complexity, it makes it a little bit more laborious on our part, obviously. Chronic care management services would probably be excluded because there is a mandate for electronic medical records for that to be compliantly billed. But, fortunately, the majority of the processes we go through do not require EHR. So, cool. Well, gentlemen, I'm going to sign off at this point and get my morning started with some other activities, unless there's anything else I can say.
Nice. Thank you.
Thank you for your time, Mr. Frost.
You bet. Thank you, guys.
Bye.